infections. Moving over from country to Mumbai, once considered as epicenter of HIV/AIDS epidemic in the country. As it was mentioned earlier, the first AIDS case in the country was found in Mumbai. Mumbai being one of the, is actually the 6th largest global city in terms of population, with 12.4 million population and 28,000 density, 28,000 people staying in 1 kilometer, and 52% population being in the slums. In last 100 years, there has been almost 300 times increase in the population of the city. When we look at what has been the response to this HIV/AIDS epidemic in the country, 86, the first case of HIV infections found in sex workers in Chennai. Setting up of AIDS task force in 1989 by ICMR and AIDS committee. 1990 were the place where, was the year when the medium-term plan was launched, and 1998 was the year when MDAX was established. If we look at what we have done in Mumbai, by Mumbai Municipal Corporation, the first project for ASHA, named as ASHA, was launched in the Kamatipura area of females, where majority of the female sex workers were located. It found a very high prevalence of HIV among the sex workers in that year, almost more than 60%. HIV screening in all the blood banks was launched in 1994. There was also an health information gallery, the first in Asia, called as Antarang, established in our STD clinic there. With the implementation of various phases of National AIDS Control Program, right now we are in the phase 4 of 2012 to 17, where the focus is more on integration into the existing health infrastructure set up by the government, state government, as well as the local government. As laid down by the NACO, we have various divisions under the Mumbai District AIDS Control Society. We have the services of basic services, which looks at counseling, testing centers, program of PPTCT, interventions for the mothers, diagnosis of early infant diagnosis. We have sexual and reproductive health services established through DSRCs or the STI clinics for diagnosis and management of people with STDs. We also have care support treatment centers giving ART to the PLHAs. We have targeted interventions for key populations through their own NGOs and CBOs. And woven through all this is our IEC and mainstreaming divisions. We also have blood safety. As it has been mentioned, HIV in the country is concentrated among the key risk groups of female sex workers, MSM, IDUs, TGs, from which the clients, majority again from the migrant workers and truckers, get infected, and it is through them it reaches the general population and pregnant women being diagnosed as one of the proxy indicator from whom the newborn babies are being infected. What is it that we see in Mumbai? This is HS's HIV prevalence among high-risk groups. We have in the red line, the trend line of India, and versus we have the blue trend line for Mumbai. If we can see here, in 2003, among the female sex workers, the positivity was 54.3%, which has come down to 6.2% in 2015. IBBS data. Similarly, among the men having sex with men, the HIV prevalence has come down from 18.4% in 2003 to 4.9% in 2015. When we come to the next groups of IDUs and transgender, we see that among the IDUs, the registered population also has gone down significantly in Mumbai. The positivity has come down from 15.6% to 1.3%, and amongst transgender, it has come down from 49.3% to 15.3%. So this shows a very significant reduction in positivity among these high-risk groups, and this has also resulted in reduction in positivity among the general clients. This graph shows over the years the number of people availing ICTC facilities in Mumbai. So right from 2001, where there were hardly 40,000 people accessing the testing services, counseling and testing services, if we look at 2015, we have around 3 lakh people coming for our ICTC services. The positivity has gone down from 13% in 2001 to 2.5% in 2015. As it was mentioned by the chair earlier, because the numbers have increased, the numbers getting tested have increased over the years, which may give low positivity. But if we look at the actual numbers coming positive, the number of people who are diagnosed as positive, in absolute numbers also, it is showing a decline. And this is also reflective of the decline that we see in the number of diagnosed patients at the national level also. So the number of PLHS diagnosed has now come down to around 7,283 in 2015-16. Among the ANC women, we have in Mumbai around 1.5 lakh deliveries happening every year. Around 1.2 lakh get tested in our services, the hospitals, maternity homes, etc. The number getting tested also shows an increase from 2003, and it is now almost steady with access to majority of the health facilities where women are accessing these ANC care. The ANC women diagnosed HIV positive has also shown a decline, and we had a very high number of both new as well as known positives of 1,000, above 1,000 in year 2006. Now it has come down to newly diagnosed women seropositive to just 215. If we look at HSS information, here again the red trend line is for the country, which is showing just 0.29% at the national level HSS positivity prevalence among the ANC mothers. In Mumbai, out of the 8 sites that we have for ANC HSS prevalence, it is showing a decline, but in few sites there is still high positivity, and these sites, as we'll be seeing later on, it is not an heterogeneous prevalence, but there are few wards, localities in Mumbai which has got high number of ANCs getting diagnosed or newly diagnosed being positive. Over the years, if we look at this shows from 2005 to 2010, the positivity, the prevalence amongst the various age groups, as it can be seen, 25 to 49 age group still remains the predominant age group coming positive in our city. The positivity has come down significantly over the last 10 years in all these age groups. Proportion of male to female has remained constant over the last decade to 63, 64 men versus around 35 to 36 women. And this is also reflective of the national proportions. A very sensitive indicator, number of children who are registered. And if we see how many children get registered for our ART services across the ART centers, that is showing a decline from 500 children which were registered in 2010 to just 159 in 2015-16. ART scale-up. The first ART center was established in Mumbai in JJ Hospital in 2004. Right now we have 15 ART centers, 2 with private collaboration in L&T and Godrej Hospital. Around 32,000 PLHs are on ART treatment, and 46,000 are currently active. When we look at where these diagnosed people, PLHs, are coming from, when we look at these spot maps, it can be seen very clearly that 26% of these patients who are diagnosed in the last year have come not from Mumbai but from outside Mumbai, different districts of the state. And 1% of patients are from even outside Maharashtra, from other states in the country. So when it comes to achieving 90-90-90, to link these people found positive to ART centers becomes a real tough challenge for us. We do have started a lot of activities for migrants, truckers, our youngsters, as well as with various local self-help groups to reach to larger population coverage. As I mentioned earlier, where these cases are coming from within Mumbai. And if we look at, and if we do the if we have done the geoprioritization of the epidemic for the city across the 24 wards of Mumbai, and we see that amongst the existing PLHs registered for treatment, as well as newly diagnosed PLHs and the HRG, that is the key population presence in a particular ward, looking at all these variables, we have around 11 wards in the city which are showing high presence of new infections as well as existing PLHs. And these wards are also having high slumps in their wards or high HRG, which is contributing to increasing transmission in these wards. We have also tried to mainstream with other public health sectors because Mumbai also has a large presence of central government institutes. The testing amongst these employees or the people availing those services, knowing that almost 50% of our deliveries happen in the private sector, and this private sector could range in terms of quality from a small room in the slum to a 5-star tertiary institute, but the seropositive pregnant women could be going to any of these facilities. We have tried for achieving elimination of neonatal HIV transmission to reach out to the entire universe of pregnant women, tried to have collaboration with the private health sector. We have also now converged with NHM by increasing our FICTC presence. And we are now one of the city identified for Fast Track City initiative to achieve 90-90-90 by 2020, and trying to link up with the various vulnerable groups of rickshaw drivers, the police, MSM, and hard-to-reach population is one of our strategies currently. So when we look at, has the epidemic changed over the years? Yes, definitely. We see a declining trend in HSS prevalence among high-risk groups and ANC women. We also see low positivity among general clients. The number of HRGs coming positive is hardly 0.5% of the total cohort. We have reduction in the PMTCT transmission from the mothers to babies to 0.04% with launch of ART, early ART for all pregnant women. We also see a shift in epidemic from HRGs to the bridge population, and we are identifying new vulnerabilities among the young people with change in the sex trade, with more use of mobile phones for solicitation, etc. The conventional targeted approach at the localities is not found to be reaching to the entire coverage. So we are expecting a shift also in that sector. Thank you.
We now move on to